the guy who started it first recognised probiotics, if you like, or the use of probiotics was this guy Mechnikov, and he was the founder of immunology. So, and what he found, he saw that there was this fantastic community of bacteria that existed in our gut, and he said that those types of bacteria are very similar to those types of bacteria that are in yogurts, and that might be the reason why yogurts were so healthy and fermented foods were so healthy, because it's the same type of bacteria that are in yogurts that he saw colonizing the intestinal epithelium. So he said maybe that there is a link there, and of course he was right, and very clever guy. One of the things that we'll be talking about today in terms of probiotics is our probiotics, and we call our probiotics Lab 4. And very simply, the reason for this is that it contains 4 different strains. So our strains, we have 2 strains of Lactobacillus acidophilus. So Lactobacillus acidophilus strain 1, Lactobacillus acidophilus strain 2, Bifidobacterium bifidum, and Bifidobacterium animalis. It was called Lactis, but it's had its name changed. So 4 organisms, and they're all part of what we call the lactic acid bacteria. So very creatively, we called ours lactic acid bacteria, or Lab 4. Very imaginative name. So Lab 4 is these 4 strains here. This is what Lactobacillus acidophilus looks like. Let's change hands. It's like a rod. Getting my coordination all wrong here. It's like a rod shape. It's like a rod-shaped organism. So it's this kind of shape, just a rod, and over here, this is a Bifidobacterium bifidum, and that's the Bifidobacterium bifidum there. It's kind of like a Y-shaped organism, and that shape is called the bifid shape. And I learned that when I was in university, when we were looking at these types of organisms, that Bifidobacterium have this bifid shape. But I had heard that term once before, the bifid shape. And it was when I was about 13 years of age, and it was a biology lesson. And what the biology teacher came up with at secondary school was that male kangaroos have a bifid-shaped penis. Did you know that? You do now. You do now. Well, to a 13-year-old, that's really important information. I don't remember anything else that happened in that biology class. In fact, I don't remember anything else that happened in that whole biology year. But I do remember that little. I don't know why she said it, but that kangaroos have a bifid-shaped penis. Probably there's people googling now, going, "Is this right?" Googling on their phone, "Is this right?" It is right, and the reason that I say it is because every time you see a probiotic pack now, and you look down, what's in it? You go, Bifidobacterium. You go, oh, you'll think of the male kangaroo as well. So it's a good word association. So let's talk now about benefits that probiotics have. And by doing that, I'll be illustrating some of the trials we've done on our probiotics. And trials, when I mean trials, I mean studies where we've got patients, we've done studies associated with medical schools and so on and so forth. And so let's look at some of the things that probiotics are used for. Let's look at antibiotic-associated diarrhea first of all. Antibiotic-associated diarrhea is related to between 3.2 and 29% of all antibiotic courses. So it's a very common event that you probably have patients or customers coming back to you in some frequency saying, "Oh, I got a bit of diarrhea when I took that antibiotic." You come across that? Yeah? So it's a common thing. Sometimes it's quite serious, and sometimes it can be very serious if the antibiotic-associated diarrhea is C. difficile. That is normally associated with hospitalized patients, but it's more and more coming into the community. If you have C. difficile associated diarrhea and you're elderly, that can be a real problem. It can kill you. So C. diff is a big issue. It causes a really nasty diarrhea, really nasty enterocolitis. And it's in Ireland. If we go back, antibiotic-associated diarrhoea, between 10 and 20% of cases tend to be C. diff. In Ireland, there's about 2,000 new cases of C. difficile-associated diarrhoea annually. And that doesn't include ones where it occurs or reoccurs. These are new cases. Reoccurrence is a real problem. Some people have C. diff and they have it as an issue, and it can go on for months and months and months, sometimes even years. And there are more and more virulent strains that are being found now as well. So it's an increasing problem. Let's look at then some of the trials that have been done looking at antibiotic-associated diarrhoea. And the first thing I've done here is collected two what we call meta-analyses together. Anybody know what I mean by that, a meta-analysis? A meta-analysis is where you look at all of the studies that have been done and you group them all and you say, what's the overall effect? So you take all the studies that have been done over the years on different products and different ways and you kind of group them as best you can. And you say, what's the overall effect? Well, an antibiotic-associated diarrhoea, by giving probiotics, this is adults here, by giving probiotics, then you'll get a 42% reduction in risk of getting antibiotic-associated diarrhoea. And that was over 12,000 accumulated patients. So it's a very consistent effect, even better in kids. So antibiotic-associated diarrhoea in kids, you get a 55% reduction in risk of antibiotic-associated diarrhoea by giving a probiotic. Okay. So there's a consistent effect, and from a medical point of view, from a doctor's point of view, you can now point to this as a reason for providing or for recommending or at least asking the person to consider the use of probiotics, because there is this documented benefit of consistent reduction in risk of antibiotic-associated diarrhoea. In that meta-analysis was included our trial, and our trial, the first trial that we're going to tell you about today, we did at Cambridge Hospital, Addenbrooke's in the UK, alongside Cambridge University. Again, it was a double-blind, placebo-controlled trial. We used ProVen adults. Where are we? So anyway, we used acidophilus and bifidus for adults in this trial. We've used that particular product, our hero product, in most of our trials, and I'll go through that. It'll be, I don't know if we've got one. Mrs. John? No? Okay. So, we will try and get a picture of it. R-Rager's, I can see it. Yes, we have the technology. It's called a bucket in the back of the room. So here we are. And this is our adult acidophilus and bifidus 25 billion. This is the product that we've used in most of our trials. This is the actual product that was used in this trial. And bear in mind, most products out there on probiotics are not the actual product that's been used in the trial. They may have accumulated some strains from somewhere, brought some other strains in from somewhere else, not the product that was used in the trial. When we show you our products, and I talk about a product being used in our trial, this is the product that was used in this form. Okay, so what we did here, this is our product here. I'll just put it there. So what we looked at was, this is in Addenbrooke's Hospital in the UK, 150 patients who were looking at taking antibiotics. And it was actually 2 capsules a day. 2 capsules a day provide 25 billion of our lab 4 probiotics. 2 capsules a day here, 2 capsules a day provide 25 billion of our lab 4 probiotics. And we were looking at 3 things. The presence of C. difficile, the presence of C. difficile toxin, and the incidence of diarrhea. And as you know, in these clinical trials, what you do is you divide your patients up. Half take your treatment and half take nothing, or placebo. Yeah? Okay? Right. So we were looking at, let's say, incidence. We're looking at presence of C. difficile diarrhea in the people's guts, presence of C. difficile toxin, and incidence of diarrhea. This is what we found. So this is the outcomes. What we found when we looked at the presence of C. difficile in these people's GI tract, intestinal tract, was that the placebo group, 13% of the people had presence of C. difficile. In the probiotic group, 16% had. So there's no real difference. So the probiotic didn't get rid of the C. difficile, interestingly. But then we looked at C. difficile toxin. Remember what I was saying about toxins? The reason that C. difficile produces diarrhea is it produces toxins. The toxins then interact with the epithelium of the gut and then cause diarrhea. What we found here was that in the placebo group, 78% of them we could find C. difficile toxin. In the probiotic group, in the ProVen group, only 46% produced toxins. So that was a significant difference. Then, because it's the toxins that cause the diarrhea, what we found was that in the placebo group, 67% of the people who were positive for C. difficile went on to produce C. difficile toxin, diarrhea. And in the probiotic group, only 18% of those who were positive for C. diff went on to produce C. difficile associated diarrhea. So the probiotic produced a fourfold reduction in risk, of C. difficile associated diarrhea. So you might think, what's going on there? Well, what we almost certainly know is actually happening. The probiotic is not getting rid of the C. difficile from the gut, but it's coating the gut wall, and it's blocking C. difficile from attaching to the gut wall and hence producing toxin and hence producing diarrhea. So it's not eliminating Clostridium difficile from the gut, but it's stopping it from attaching and producing toxin and hence diarrhea. And this is still probably the best C. difficile trial that's been done in terms of clarity of effect and potential mechanism of action on probiotics anyway. Okay, let's look at non-Clostridium difficile associated diarrhea, antibiotic associated diarrhea. And here we were looking at 3 types of organisms that cause antibiotic associated diarrhea but are not C. difficile. So you've got the coliforms like E. coli, you've got staphylococci and enterococci. These all cause antibiotic associated diarrhea but are not C. diff. Right, question. Some of you recommend probably probiotics alongside antibiotics. So do you recommend that the probiotics should be taken at the same time as the person takes the course of antibiotics, or do you wait until they finish the course of antibiotics? Let's have a show of hands again. When you're recommending a probiotic, how many give probiotics alongside the use of the antibiotic? How many wait until you finish the antibiotic? How many think it doesn't really matter? No, I'm not saying it doesn't really matter, but you don't actually think it matters. That didn't come out very right, did it? I'm sure you're very caring, very conscientious. Of course it matters. Okay. Most people now use probiotics alongside the use of antibiotics. That's correct. This was the trial that demonstrated the effect. The reason that you tend to use probiotics alongside antibiotics is because of the trial we did 10 years ago. And this is what we showed. So we had 3 arms to this trial. There were 3 parts to this trial. The first part here, the first treatment group, we gave antibiotics for the first 7 days. So antibiotics only for 7 days. In the second group, we gave antibiotics for 7 days, and then we gave the probiotic after the course of the antibiotics. So wait until we finished the antibiotics and gave the course of probiotics afterwards, because we thought the antibiotics are going to kill the probiotic. Logical. In the third group, we gave antibiotics for 7 days and we gave probiotics for the same 7 days alongside the antibiotic. Not at exactly the same time. So there's got to be at least preferably 3 to 4 hour gap between giving the antibiotic and the probiotic, but at the same time as doing the course of the antibiotics. And we had about 30 people in each of these arms, so 3 arms to this trial, and we took fecal samples on day 1, 7, 12, 17, 28, so that's 1, 2, 3, 4, 5 lots of 30 fecal samples. That's a lot of feces. And we took the first sample in hospital. So we took the samples, the first one, so we could show people what to do. And then, interestingly, we do trials with people. So the next one, what we gave them for their further fecal samples, we gave them like a jiffy bag to take away with them. And inside, you know, a jiffy bag? Inside the jiffy bag was like a Ziploc polythene bag. And inside that was like a universal bottle that's got like a captive scoop in it. Do you know what I mean by that? Little captive scoop in the universal bottle. And we had a diagram and instructions of exactly what to do. You take a little bit of your scoop and you put it into the bottle and so on and so forth. So it's very clear what should be done. It was amazing. It was amazing. We could tell when the postman arrived. I don't think they're allowed to do this anymore. When the postman arrived and and it was a bit squidgy. About 25% of these people, what they did, they must have just literally got the polythene zip bag, right, and gone, well, totally ignored the fact that there was a tube inside, totally ignored the instructions, and literally went, and then zipped up the polythene bag again, put it in a jiffy bag and sent it home, sent it to us. Great. As I've said before, it's much easier to do animal trials. Animals tend to do what they're told. Anyway, right. So this is where we got to. 3 arms to this trial. First one, antibiotics only. Second one, antibiotics followed by probiotics. Third one, antibiotics with the probiotic and also followed by the probiotic for 7 days. And this is what we found. We were looking at these undesirable types, the coliforms, the staphylococci and the enterococci. What we found in group 1 was that by 7 days, we had an overgrowth. So we had an overgrowth of these undesirable types. And that can lead to antibiotic-associated diarrhea. So we had an overgrowth of these undesirable types, leading to antibiotic-associated diarrhea, and that overgrowth sustained itself until day 28. That's important because it's at least a semi-permanent overgrowth of undesirable bacteria. Secondly, on this trial here, on this part here, the second group, where we gave the probiotic after the antibiotic, as you would expect, in the first 7 days we got exactly the same effect. There was this overgrowth, this significant increase in these undesirable types of bacteria. But by giving the probiotic here, 7 to 15 days, by the time we got to 28 days, that overgrowth had been engineered down by the probiotic. So it worked. But the interesting one was the third group. In the third group here, when we gave the probiotic with the antibiotic, what we found was that in this first 7 days, we didn't get any overgrowth at all. So by giving the probiotic alongside the antibiotic, we prevented any overgrowth occurring in the first place. And if you think about it, it's much easier, much better to prevent the overgrowth occurring than try and rectify it once it's occurred, because sod's law, next time round, you won't be able to rectify it. And this was the trial that really changed how we look at giving probiotics alongside antibiotics, because we showed this effect. So it was us. Okay. Right. But you may say, well, yeah, but surely the antibiotic is still killing the probiotic. So how does that work? What we think about is what's going on is this. Think of, in terms of how we stop this growth occurring. Think of a football stadium, and it's fully occupied. So, what is it? Croke Stadium here, Croke Park. It's got what, 100,000 seats, something like that. It's a huge stadium, isn't it? So it's 100,000 seats. Okay, think of that. Those seats, they're all occupied. And then think of that as being like your gut, where all of the gut is occupied by your friendly bugs. And then you give an antibiotic. and you wipe out 98,000 of those, in this case, people in those seats in the stadium. 98,000 of the seats are unoccupied now, but 2,000 are still occupied, dotted around. What's going to occupy those 2,000 seats? Think of it as being bugs now. It's going to be the organisms that are not susceptible to the antibiotic, like the yeast, and it's going to be organisms that are resistant to the antibiotic. And all of a sudden they go, oh, this is fantastic. All the competition is gone. 98,000 seats are now available. So we can grow and we can go and occupy all of those seats. And that's exactly what the situation is. But when we give the probiotic, imagine that's the situation when you start giving the antibiotics. 98,000 free seats, and he's going, oh, fantastic, we can overgrow. And then just as they're about to overgrow, this deluge, remember the numbers, the 25 billion in the small intestine, this deluge of probiotic comes down and occupies those 98,000 seats, and so stops that overgrowth occurring. So they go, oh, there's no more seats left, so they can't overgrow. In the next 24 hours, the probiotic organisms are killed by the antibiotic. But then you get to the same point. So 24 hours later, the 2,000 organisms, the 2,000 seats, the 2,000 bad guys are going, oh, it's fine, we can overgrow again. You're almost Groundhog Day. We're back to where we were. We can overgrow again. And just when you're going to do that, another deluge. Your next dose of probiotic comes down and occupies the seats again. So it's almost like a Groundhog Day type thing. That because you're taking the probiotic daily during the course of the antibiotics, you're producing this suppressive effect on this overgrowth occurring. Very valuable, totally valuable. And if you only have to give a probiotic, say you've got somebody who goes, I'm only going to take a probiotic for 7 days, then get them to take the probiotic with the antibiotic. Hopefully they should be taking it with the antibiotic and then following the antibiotic. But if they say, no, I'm only going to take it for 7 days, make sure they take it with the antibiotic. But again, absolutely not at the same time. Between 3 and 4 hours, if you can, apart from actually taking the antibiotic. The point is, you don't want the antibiotic and the probiotic to be in the stomach at the same time, because the antibiotic will then just kill it dead. Okay. Antibiotic resistance. One of the things that we were saying here, this is a third trial that we did. This is again at Cambridge. I think this is an incredibly important trial. No one else has done this type of trial. If you think of antibiotic use and resistance and the inexorable rise of resistance, what can we do and what are we doing to try and decrease levels of antibiotic resistance? What are we doing? Giving out less antibiotics. Anything else? Hand washing, so we're decreasing the levels of infection, so we don't necessarily need the antibiotics. Yeah. Okay. Most of the things that the governments of the world are advising are passive. They're all to do with reducing the use of antibiotics rather than anything proactive, because nothing proactive has been found to have an effect until this. This is the only trial that's been shown where an intervention has been shown to have an impact that can reduce the progression of resistance to antibiotics. And this is what we did. We were looking at these types of bacteria called enterobacteria. Think of them as being coliforms, like E. coli. And we looked at patients, these were elderly patients, and we looked at patients prior to the use of antibiotics. And we found that 18% of people in this trial had enterobacteria in their gut that were resistant to antibiotics. So 18% of patients had enterobacteria in their gut resistant to antibiotics. Right, we then gave one group just antibiotics, and one group we gave antibiotics and probiotics. What we found in the group that just had antibiotics, they started off with 18% of the patients having resistant enterobacteria or resistant coliforms, At the end of the trial, 100% of these patients had resistant coliforms in their gut. 100%. When we gave them the probiotics, the ones we gave probiotics to, only 30% had resistant coliforms in their GI tract. That's a huge difference. And it's the only trial that's been shown to, where an intervention has been shown to decelerate or stop the progression of resistance to antibiotics. And of course what we're doing now is we're doing a much bigger trial with more antibiotics, with different organisms. If we can show this effect is consistent, I think it will swing the medical community globally into using probiotics or recommending probiotics compulsorily as an adjunct therapy to antibiotics. In some places in the world, it's already happening. If you go to Russia, or you go to the Baltic states, Lithuania, Estonia, and so forth, and you talk to a pharmacist there, and you say, how many times do you recommend a probiotic alongside an antibiotic? He said, and they'll say 80%. About 80% of our scripts of antibiotics, we also sell a probiotic alongside that. So some places in the world, this use of probiotics alongside antibiotics is still very well established. Strangely enough, in the old USSR, for people who remember the USSR, in the countries related there, so Russia, the old Baltic states, which are part of the old USSR, Eastern Europe, the Balkan states, old Yugoslavia, all have this very high usage of probiotics alongside antibiotics. Very insightful. Okay, let's turn our attention to IBS. IBS, we now believe a lot of IBS symptoms. What are the symptoms of IBS? Do you get a lot of IBS coming into your pharmacy? Yeah? So what do you get? Constipation, diarrhea, bloating, pain, gas. Yeah? Those, okay. What we now understand is that a lot of IBS is probably caused by the use of antibiotics. Antibiotics cause this dysbiosis, a change in the pattern of the flora. And that then produces an onset of IBS symptoms, but it might be 3 months later. So you don't necessarily link the use of antibiotics with the onset of IBS symptoms. So we did a trial, again, it's considered to be one of the best trials on probiotics on IBS. We again used our ProVen acidophilus and bifidus for adults, and we gave 2 capsules a day for 8 weeks to people who had IBS. 2 capsules a day for 8 weeks to people who had IBS. And this is what we found. And what you measure with IBS is you measure these types of factors here. So, what we do is bundle these up to what we call total IBS symptoms. So we have number of days with pain, so giving like a frequency of pain measure, severity of pain or intensity of pain, bloating, satisfaction with bowel habit, and quality of life. So satisfaction of bowel habit, some IBS is associated with constipation, some IBS is associated with diarrhea, but when I see IBS most often now, it tends to be oscillating. People go through periods of constipation, then periods of diarrhea, constipation and diarrhea, and what it means is they have very little control and prediction over their bowel habit. And that often means in severe cases they can hardly go out because they don't have any control. And that obviously affects their quality of life. So what did we find in our trial? One of the things that we found is, like a lot of IBS trials, we saw a strong placebo effect. So this is the decrease in total IBS symptoms. We saw, along with a lot of trials, that we saw a strong placebo effect. And that indicates immediately that IBS has a strong emotional and psychological component to it. It's not just physical. So you get a strong placebo effect. But look what happened with the probiotic group. Within 2 weeks, the probiotic group were already diverging from the placebo group here. By 4 weeks, there was a greater divergence. By 6 weeks, it was a significant decrease compared to the placebo group. by 8 weeks there was a greater significant difference. So we saw a strong, significant difference, a strong, greater reduction in IBS symptoms in the probiotic group compared to the placebo group, which is what you want, obviously. So that was the first outcome. The second outcome was that when we took the probiotics away, the symptoms started to come back. And that's typical with people who have IBS. They will normally need to be on a probiotic, maybe almost indefinitely. So how I work this in the UK, somebody who's got IBS, I get them to take 2 capsules a day for between 12 and 16 weeks. So 2 capsules a day for between 12 and 16 weeks. You will see the symptomology decrease. You will see it go down. And then what I do is put them onto 1 capsule a day. Just see how they go. And I say to them, if you start to see any symptoms coming back, you go straight away back onto 2 capsules a day. And you just keep on working it like that. It works fantastically well.